A timer that is going to be on
Yeah,
this.
live.
Hi, everybody. Good evening and good morning from wherever you are listening throughout the globe. Welcome to the AIOS AOC session. This is an APVRS session on Pachychoroid. Everything you need to know about Pachychoroid and the new knowledge in 2025. It's my honor to introduce the chairpersons, Dr. Anand Rajendran and Dr. Giridhar sir, and moderators, Dr. Piyush Bansal, Dr. Abhishek Kothari, with the panel of Dr. Chaitra Jaydev, Dr. Dinesh Talwar, and Dr. George Manyat. Dr. Piyush and Dr. Abhishek will introduce the speakers. Thank you.
Thank you, Dr. Vaibhav. And first of all, welcome to this fantastic session. Now we have some excellent expert panels. To begin with, we have chairing the session, Dr. Anantharaman Giridhar. Sir is the director of Giridhar Eye Institute in Kochi in Kerala, and he's the past president of VRSI and has done pioneering work in PDS, in Pachychoroid disease spectrum. We have Dr. Anand Rajendran, who's the Chief of Retina Services at Aravind Eye Hospital in Chennai and the past chair of the Scientific Committee of VRSI. We have Dr. Dinesh Talwar, who's a senior consultant, ophthalmologist and retinal surgeon at Center for Sight in New Delhi and Apollo Indraprastha Hospitals in New Delhi, India. We have Dr. George Manyat, who's a senior consultant vitreoretinal surgeon at Aravind Eye Hospital in Coimbatore in India. And we have Dr. Chaitra Jaydev, who's the head of vitreoretinal services at Narayan Nethralaya in Eye Institute in Bangalore in India. Now, I would also like to acknowledge and thank Professor Paisan, who's the Scientific Secretary of APVRS, Professor Andrew Chang, the General Secretary of APVRS, and Dr. Santosh Unawa, the General Secretary of AIOS, for this joint AIOS APVRS session and all the support that was provided. With this, we can perhaps start with an opening remark by Dr. Giridhar, sir.
Yeah, thank you. Thank you very much. And thanks a lot for inviting me to be the chairperson of this very interesting session. We are going to discuss the complete spectrum as far as the pachychoroid is concerned, right from central serous chorioretinopathy, macular neovascularization in pachychoroid disease, polypoidal choroidal vasculopathy, and the atypical presentations. I think it's going to be a very interesting session. And I would say that this is something in evolution, because I don't think still we have got enough what you call evidence to really, define many of these features and also understand the pathogenesis. In fact, some of the cases that we see now in our practice, especially when we do multimodal imaging and especially indocyanine green angiography, we are seeing a lot of new features, which probably to a certain extent we are not able to explain. And we are also not able to find solutions as far as the treatment is concerned in some of these patients on a long-term basis. So with this introduction, I would like to see what this panel is able to present, what are the new views that are coming in, and how this finally is going to improve our practice and our patients. And I hope we'll have a very fruitful discussion. I invite all the speakers and the panelists and also the case presenters. I think we have got a couple of very interesting cases too. And I think together, all of us can definitely contribute a lot in this particular session. Thank you.
Yeah, so we'll begin the session with the first talk from Dr. Anirudh Agarwal. Dr. Anirudh joins us from UAE, from Abu Dhabi. He's an associate professor in the Cleveland Eye Clinic. His areas of interest are medical retina, and he has published quite a bit in medical retina in UVA. Over to you, Dr. Anirudh.
Very good evening, good morning, all friends and colleagues from around the world. I hope I'm audible and my slide is visible.
Yes.
Yeah,
Please
thank
go
you.
ahead.
So again, it's a pleasure and honor to be here, and I'd like to acknowledge immense work done by the chairpersons, Dr. Giridhar sir, Dr. Dinesh Talwar is here. Greetings to the chairpersons, to panelists. And also, I'd like to acknowledge specifically Dilraj. He's here, one of the speakers who helped me initially understanding pachychoroid, long ago through his slides. So I'm just going to talk about the pachychoroid spectrum, a brief introduction to the spectrum itself and pathophysiology. And then we'll have a series of talks on different aspects of the pachychoroid. So I'll start with the basics, which is the choroidal anatomy. And remember that choroid is responsible for, 1/3 of the vascular support, the external vascular support of the retina also. And so any impact on the structural integrity is going to impact the retinal function. And a compromised volume or flow, either of them could result in photoreceptor or RPE dysfunction. The choroidal blood supply derives branches from the anterior and posterior ciliary arteries. As mentioned in the opening remarks, we still are not very clear what is pachychoroid. We all know it's a thick choroid, but we still do not have a definitive cutoff value of how many microns and above you would define it as a pachychoroid. There is a working definition that different researchers would use in their papers, but we don't really have a universally accepted number. One of the component of pachychoroid, which is really important, apart from increased choroidal thickness, is choroidal hyperpermeability, often for which an ICG is extremely useful. Along with sometimes you have pachy vessels, which are dilated outer choroidal vessels, and or you may also have the posterior terminal morphology of the pachy vessels may be club shaped, and that could be something that also could be seen on ICG. An important component of pachychoroid is thinning of choriocapillaries. So when there is attenuation and thinning of choriocapillaries, that forms one of the most important pathophysiologic mechanism of the manifestations of pachychoroid. So essentially there is a differential flow in the choroid compared to the outer choroid and the inner choroid. So in simple terms, there is thick choroid, which is characterized by dilated and hyperpermeable vessels, and there may be a breach in the Bruch's membrane and RPE, along with dysfunction of the RPE that could lead to serious retinal detachments. So the spectrum of pachychoroid is not limited to these 5 entities. It's actually gone beyond now. We have central serous as one of the component. Of course, you have pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, PCV, pachydrusen, and of course, we also have others such as focal choroidal excavation, some of the other entities that are now being included in the pachychoroid. We'll have a detailed talk, I think, by Nopasak on the new concepts in pachychoroid, but there is an increasing interest now with Vitelliform disease. They may have accelerated pachychoroid. So this is something which is a new concept. Also, conditions such as sleep apnea, OCDs, and some of the other conditions where you have a role of endogenous endorphins, they may also contribute to pachychoroid. So it's important to understand that pachychoroid, the reason why we are focusing so much on pachychoroid is that when you have a thick choroid, it behaves differently compared to patients, those who have a non-pachychoroid disease. So on one side of this, the sand clock, you have choroidal hyperpermeability, you have thick choroid, and you have manifestations such as polyps and BVN. And on the other side, we are battling a number of outcomes such as foveal thickness, closure of the polyps, visual acuity, adverse events. These are various outcomes that we use in clinical practice, in clinical trials. And many of these outcome measures, they're not clearly defined in the literature. We don't know if choroidal hyperpermeability is going to affect the thickness or whether that has an impact on polyp closure. How does thick choroid or even polyps, they contribute to visual acuity changes? These are certain things that are still not answered very clearly in the literature. There is also a concept, and Ashish Markan is one of the speakers also. Together, when we were in PGI, we did a bit of work on vortex vein engorgement. And vortex vein engorgement has been published that could be responsible for pachychoroid. You may have a single quadrant of the vortex vein engorgement seen on wide field ICG. And in that particular quadrant, you could have manifestations of pachychoroid. So vortex vein definitely could be a part of this spectrum. It could play a role here. And there are correlations published between vortex vein engorgement and choroidal thickening, and also PCV, manifestations of PCV. So if you do an NFAS, you will see that pachy vessels, they form the hallmark of pachychoroid disease. And so when you do serial cuts, volumetric scans of the choroid, you will see these pachy vessels deep in the choroid. Pachychoroid pigment epitheliopathy is the condition where there are changes which are only affecting the pigment epithelium, that is the RPE. And this could happen in any age group. So you have this young patient here with hyperreflective material above the RPE, and you have a very thick choroid. This is the area where you have the pigment involvement, but there is no neovascularization. So this is not a neovasculopathy, this is PPE. And again, if you do ICG, you will find choroidal hyperpermeability. Again, those who are interested in research, it is very difficult to define what is hyperpermeability. In general, hyperpermeability has been defined as multifocal areas of hyperfluorescence on ICG with blurred margins. And associated with that, you will see these large PEDs. Sometimes you have these Brooks membrane disruption and elevation in the Brooks membrane. This is another patient here where you have a thick choroid and you have drusens, you have these pigment epithelial detachments lying above them. You also have presence of peripapillary thickened choroid. So the scan which is on your top right shows you that the choroid is specifically next to the optic nerve is thickened, and this is a spectrum called peripapillary pachychoroid spectrum, and it could be accompanied by intraretinal fluid or even subretinal fluid. Again, you have this patient here with a focally dilated Pachy vessels, and above that there is this pigment epithelial detachment. So you could have even pachydrusen, which are presence of drusen, with underlying large choroidal vessels. So these are a number of manifestations that we see in patients of pachychoroid disease. Using OCT, I think you can really diagnose PCV in a large majority of cases. You'll have these features such as hyperreflective membranes, rippled RPEs, along with breaks or breaches in the Brooks membrane, subretinal fluid with these elongated photoreceptors, a peaked PED, a double layer sign, a tall peaked PED, and these often correlate when you co-localize on ICG, you will see these features on OCT. And all of these are essentially manifestations of increased choroidal hyperpermeability. The pachychoroid pigment epitheliopathy also has a huge spectrum, within the disease itself. You have subtle changes like RPE bumps, or you may have these small serous detachments of the RPE. You may have these focally dilated choroidal vessels beneath the RPE lesions. And so they cause overlying changes in the Brooks membrane. You may find these changes in fellow eyes. So you may have one eye with CSR or CSC, but other eye with pachychoroid pigment epitheliopathy. So you should always be on a lookout for any subtle manifestations in the opposite eye. Like I mentioned before, focal choroidal excavation with type 2 neovascularization, sometimes you may or may not have these neovascularization, and that is also now included as a feature of pachychoroid disease, because increased choroidal thickness with loss of choriocapillaries can also be a driver for neovascularization in these eyes. So the mechanism is a breach in the Brooks membrane along with drive for neovascularization. Again, you could have a situation where you have focal choroidal excavation with development of CSR, and all of these are also related to the same pathophysiologic mechanisms that we have just talked about. In the future, hopefully, we will have automated calculation of choroidal permeability by third-party softwares or automated algorithms, and this may give us more insights into the mechanism of the condition. Thank you very much, and I'm very happy to take any questions. Thank you.
Thank you, Dr. Anirudh. One for finishing in time and so crisply, summarizing the existing knowledge on pachychoroid and its manifestations in the eye. Now, my question to the panelist, Dr. George Manayar. Now, basically we started out with with understanding pachychoroid in CSCR, then to and then to subsequently several other diseases. What do you think is the significance of pachychoroid changes in the other eye? How would you treat a patient, or what would you counsel a patient who has pachychoroid or early changes in the other eye in a patient with CSCR?
Yeah, Usually what we see, this is a bilateral. Pachychoroids are usually bilateral thing, and then when you see the other eye, you will see some changes as already shown by Anirudh, that about these pachychoroid pigment epitheliopathy is usually a form of CSCR, and then those changes are usually seen in the other eye. So basically, the CSC can happen, keep happening in both the eyes. So the patient need to be told that the same disease can, recur or happen in the other eye, and then we take the, precautions, whatever he was mentioning about the, if the patient has an underlying sleep apnea or type A personality, most of them have sleep disturbances and all these things. So correction of the underlying cause, it may be different for different person. Maybe it is a steroid inducer. Already he mentioned about the systemic cortisol levels or endorphin levels and all these things. So if there is anything underlying, is something which we can prevent, or reducing the stress, so that it doesn't happen in the other eye. First thing, so to wind up, make him aware that it can come in the other eye, and then try to find out any reason that is there, and then try to correct it so that we can avoid. Because if you have CSC in the one eye, that eye is predisposed to turning into a PCV also in the later. So if you can try to halt the underlying cause, then you're doing him a favor by preventing it in the other eye, if there is an other eye.
That's exactly what I was coming to, George, that we know that sometimes it can actually go on and have a PCV like manifestation also. So these are the patients where probably
many patients either develop a CNVM, either a secondary CNVM or a pachyneovasculopathy. I think somebody will be touching on that. So pachyneovasculopathy or a PCV, all these three are possibilities in a patient with recurrent or chronic CSC.
I think Abhishek, do we have, the question is, do you have something to prevent this from happening? I don't think we have anything to, I advise my patients with CSR to do all kind of mindfulness exercises and things like that. But I don't think that we really have any solid, treatment modality to treat.
Yeah, you're quite correct, sir. So you're quite correct in the sense that, right now we are in the phase like Dr. Giridhar had, alluded to previously, that we are just beginning to understand the disease. And I think this is the first step which will enable us to, maybe, form a strategy or come to a treatment that can actually, help in addressing the pathophysiology here.
Yeah, so maybe at the end of all the lectures, we can see whether we have a situation where we can say, okay, this is what you could do. But in the beginning, if we say that, we may send a message to those who leave in the middle that, look, we have multiple strategies which can work, and now you've just missed them because you went early.
With that, sir, we'll move on. I think
I just wanted to add one point to all that George said. I think as far as the fellow eyes are concerned, I think at the initial visit itself, an autofluorescence will be very useful, because autofluorescence will tell us whether that patient has already had an episode of CSCR, some focal areas of increased autofluorescence away from the fovea, which tells us, yes, this guy might have had an attack already in the other eye. So that's a very useful method, actually, in CSCR to find out evidence of previous attacks.
Autofluorescence also can show you the leakage point, as you will see later.
Right, sir. So with that, we move to the next talk, and the next talk is by Dr. Alessandro Papiani, joins us from Italy. He is a specialist in retina and in medical retina, and he's currently based out of Monfalcone, and he's a very good friend of mine. And let's see what he has to talk about. About CSCR. CSCR was the disease where we started looking for pachychoroid in the beginning, and that basically sparked our interest in this entity. Over to you, Alex.
Hello,
just to add,
everyone.
Alessandro will be speaking about multimodal imaging in CSCR and the entire spectrum. So welcome, Alex.
Exactly. Thank you for the invitation, to the organizer, to the good friends Pijus and Abhishek. So this is an excursus of how imaging changes in the years from 2010 up to date, and how ultra-wide field imaging can, I'm sorry, here it is, how multimodal imaging can help us in the diagnosis and the follow-up in the treatment and in the treatment of this disease. I will begin with this case where we can see the near-infrared autofluorescence, the blue light autofluorescence, the OCT with the spectrum domain, and the fluorangography with the leakage point. What we can see is these focal autofluorescence alterations in both near-infrared and blue light autofluorescence in the leakage area. And during the follow-up, we see that the elongated photoreceptors lose the homogeneity that they have during the follow-up. So we decide to go forward and to treat this patient with subthreshold treatment, laser treatment in the area of the leakage. And we see after the reabsorption of the subretinal liquid that in the area where we have this interrupted elongated photoreceptors, where the ESOS is not so homogeneous, we have the sensibility map on microperimetry have lower values. So we analyzed this focal alteration of the autofluorescence in near-infrared blue light and OCT. We described these different patterns with different visual acuities in IOVS in 2012. And these elongated photoreceptors and the alteration that they have already been described years ago from Felice Cardillo-Piccolino. Also, Tetsuya Shikiryu described how these alterations in autofluorescence and the alteration in OCT going next one to the other, but he used a time domain OCT in this case. So we make this research where we compare this type of autofluorescence, near-infrared blue light, FFA, and also the spectral domain OCT, and we see how the autofluorescence and the outer retinal layers change in the follow-up. And in the areas where we have hypoautofluorescence, we have also focal atrophy of the outer retinal layers. And also, if we go through the near-infrared autofluorescence, we will find that we have different hyper-autofluorescent spots. We have these big spots here that are associated with these hyper-reflective spots near the retinal pigment epithelium. And we have these thin, small, hyper-reflective spots that are associated with these hyper-reflective spots in the outer retina. These all are caused from debris from the cells that they're dying when we have this stress due to the subretinal liquid. So we can say that homogeneous stalactite pattern and homogeneous regular autofluorescence is predicted, is good positive predicting finding, and we need to treat patients before they lose this homogeneous pattern on OCT and in autofluorescence. Other findings is these hyperreflective areas in OCT in the area where we have the leakage. And also in the areas where we have the leakage, we have this alteration of the retinal, typical alteration of the retinal pigment epithelium. Also, these findings can be described from another Japanese author, Ari Shinojima, we see here. And let's go to the pachychoroid. In 2011, I was focused on this patient. This patient had one eye with a thick choroid and the other eye with a normal choroid. And we see the eye with the thick choroid have the subretinal, the presence of subretinal liquid, this pigment epithelium detachment in the leakage area. And we see the comparison between the two eyes, 410, the eye with the thick choroid, 207, the fellow eye. And this is another case, 700 microns against 570 in the fellow eye. And we see how this thickness changed in the follow-up till the resolution of the liquid, where we passed from 700 microns to 500 microns of thickness. So also these findings can be described from Yutaka Imamura in 2009. And I would like to focus in this case. This is something different. We have a thick choroid without important subretinal liquid, only here. And the eye with more, the fellow eye with more subretinal liquid and this cerebroretinal detachment have a thinner choroid in comparison with the fellow eye. But if we go and we check the scans in the area where we have the leakage, we will find these focal pachychoroidal vessels. And we see that there is an entire area with focal pachychoroidal vessel that is associated with the leakage. And we see here the multimodal imaging, and we see the follow-up of this patient. We see when we have the resolution of the subretinal liquid, the macular area become thinner, and also the focal pachychoroidal vessels also become thinner. And let's go to this other case. We see this case with this focal pachyvessel. He have a subthreshold laser treatment. We have resolution of the liquid, but a recurrence some months afterwards. And then we decide to perform half-fluence PDT. And then we have a final resolution of this subretinal liquid. And we see also that in the follow-up, this pachyvessel, that we have multimodal imaging of this vessel here, this pachyvessel become also smaller, and also the entire choroid become thinner. So this focal pachychoroidal alteration have been described with different names from different authors. From the Spanish group, have been described like choroidal caverns. From the Italian colleagues, like choroidal rifts. But both there are some focal pachychoroidal alterations in the choroid. And also we can say at this point that ADI, spectral domain OCT, and swept source OCT choroidal imaging can be useful in order to select the best treatment PDT with half-fluence or micropulse or subthreshold laser in the leakage area. And let's go to this other case. This patient with spontaneous resolution of the subretinal liquid. We see the pachyvessels, the pachychoroid. We follow up the patient. We decide to do a half-fluence PDT. The liquid goes away but comes again, and also we have a subretinal hemorrhage. So it is a CNV. We had angio-CT in this period. This was 2014. I didn't have angio-CT in this period. We will find this type of polypoidal typical lesion of these patients. And we see that patients with presence of CNV don't respond to half-fluence PDT against the patients without CNV that responds very well to half-fluence PDT, and we have complete resolution of the liquid. And angio-CT can help us to follow up this patient, can show us how this CNV that respond really bad to anti-VEGF can evolve in time. And we can see here the new front of the lesion during the follow-up, during the reactivation of the lesion. And another important aspect of multimodal imaging of pachychoroid and central serous choroidopathy is the wide field imaging. And there is this beautiful work that describe this intervortex venous anastomosis in the macular and interpapillar area in this patient. And we can see this is a patient that I examined yesterday. This is a patient with diabetic retinopathy associated with, we see here chronic central serous choroidopathy, the multiple alteration in the autofluorescence. In the wide field autofluorescence, we see here this gravitational deposit of the subretinal liquid. So we perform angio-CT, we see the diabetic retinopathy, and we have done yesterday ultra-wide field angio-CT to this patient. And we can see here the pachychoroid vessels, the intervortex venous anastomosis in the macular area and next to the papilla in the left eye. And we can see also in the ultra-wide field scan the presence of the subretinal liquid in the area where we have this alteration of the autofluorescence in the previous images. And in these vascular density images, we can see how dense and huge are these vessels in the area of the anastomosis near to the papilla in this eye and the macula here. And we see also in the B scan these pachyvessels. So I want to conclude telling that this central serous choroidopathy is a pachychoroid spectrum disease and have 4 steps. In the first step, we don't have important alteration in the autofluorescence in the OCT scan. The second step of the disease, we begin to have alteration in the autofluorescence. the second step, we have the subretinal liquid. And in the fourth step, we can have the complication with polypoidal choroidal neovascularization. So multimodal imaging can help us to decide which is the correct treatment for this patient. That can vary from laser, micropulse or subterator laser, half-fluence PDT, or anti-VEGF treatments in case of presence of polypoidal choroidal neovascularization. Thank you very much for your attention.
Thank you, Alex, for taking us through this whole spectrum and creating a kind of a temporal graph as to how the changes appear and how they appear on each of the multimodal imagings. Now, I have a couple of questions. Is there data on the temporal changes in the pachychoroid vessels versus the changes in the overlying retina? Let's suppose in CSC, we know that when the CSCR becomes chronic, you have retinal thinning, you have retinal atrophy. So is there any correlation to the changes in the choroid to the changes in the retinal thickness, or the presence of intraretinal fluid inside the retina, which are basically bad prognostic markers?
What I focused is that in the active moment of the disease, we have thick choroid, and this become a little bit thinner when we don't have an active phase. So this can be predictive. We follow up the patient in order to decide if we want to treat him or not. I focus on different aspects. One is in the aspect of the elongated photoreceptors that I want to be homogeneous. The other is the autofluorescence, but also in the thickness of the choroid. And if the choroid begin to become thinner, this is a good predictive factor. Maybe we go we go in the direction of the resolution of the disease, without treatment. If we have the choroid maintains thick characteristics and we need to lose the homogeneity of the autofluorescent of the elongated photoreceptors in the OCT, is better to treat the patient and don't wait.
Can I ask one question? I mean, Abhishek, can I ask one question?
Sure, sir. Sure, please go ahead, sir.
Yeah, I mean, very interesting talk, sir. What I want to ask you is, I personally feel CSCR has got multiple phenotypes. It's it's got multiple phenotypes. Not all presentations are the same. I mean, there are patients who have these bilateral disease, which are very chronic, and they finally progress to macular degeneration. But on the other hand, you have patients who only have a unilateral disease. I mean, and there are patients who develop CSCR much later in life. It's a CSCR, it's not neovascular, but at the age of 40, 45. But there are patients who develop it at a much younger age. So personally, I feel, and there is something called a peripapillary pachychoroid syndrome. So there is, I mean, it's a large phenotype of disease. Do you agree with me on that? And I mean, we can't just say that this is how it behaves. It's
I fully agree. I fully agree with you. And we have a loss of the outer retinal barrier, blood retinal barrier. But we can have it due to two reasons. One is because we have a problem in the retinal pigment epithelium, and there are patients that they have alteration of the retinal pigment epithelium without pachychoroid vessels. They are, but is not the majority. But there are also patients that they have this typical pachychoroidal alteration, that are diffuse thichoroid or focal pachychoroid vessels that create a pressure against the retinal pigment epithelium. This creates the typical retinal pigment epithelium detachment that we see in the background image right now. And this means the retinal pigment epithelium works very well and try to stop this kind of water that comes from under. And arrives a point that cannot stop it, and the tight junction of the cells don't work very well, the liquids comes out. So in some cases, the origin, the pathophysiology is in the choroid. In a few cases, is directly in the retinal pigment epithelium. This is my personal opinion of how I see the disease, and in 95% of the cases, I find an alteration of the choroid. There are not many the patients that they don't have pachychoroidal alterations. So maybe there are some phenotypes, but there's a smaller part of the patients that have direct alteration of the retinal pigment epithelium without pachychoroidal vessels.
Right. Before we move to the last,
Just to add one line to what Girdhar sir mentioned, actually the phenotypes are so many that you can have an acute bullous fibrinous variant to old age man with bilateral papillary disease with atrophy, and then hardly any subretinal fluid, but a lot of intraretinal fluid. Then you have patients with so big PEDs at the fovea and even RP rip. So, the phenotype, basically, I feel that the newer concept of choroidal overload depends on whether it's a very widespread disease. When you do ICG for many of these patients, you see that some of them have the choroidal vascular hyperpermeability limited to one or two areas within the arcade. But when you do for some other people, we see that it's all around arcade. So I feel the answer to Giridhar sir's question is all these, like 80-year-old gentlemen having bilateral peripapillary fluid is not something. So now they are trying to look at where is this anastomosis happening. Is it around the disc, around the macula? Is it very widespread? I think that is the something answering towards your question, I feel.
We can have anastomosis in different areas. As you can see in this angio CT from yesterday, I was trying this new machine yesterday and it was amazing. You can find anastomosis next to the papillary area, next to the macular area, but also in the periphery. So these are the typical leakage areas where we have the anastomosis.
Yeah, sometimes we see only one quadrant or sometimes two quadrant, and sometimes it can be even four quadrants. So I think that answers Giridhar sir's question, I think.
I think we can have a one-day discussion on CSCR.
Absolutely. Abhishek, one point only. There are actually two major subsets of CSR. One is the chronic CSR, in most of the cases, very beautiful lecture. And basically what you showed were chronic CSR cases where autofluorescence shows a sick RPE. And if you do the ICG, that will also show a large area of sick RPE, as George is talking about. The second group of patients are those where those are acute recurrent CSR. And those patients do not have this kind of sick RPE. They have small focal area from where they leak, and which is the area of where so the RPE has given way with or without a small RPD around that area. The two are completely different entities. They behave differently. They can, the first cat, these are younger patients. They resolve in 80-85% of cases. The other group is chronic and can persist for years on an end. And the other important thing is they can sometimes persist for years on an end without causing any defect in vision. We are assuming that every time you see this, they need to be treated. I can show you multiple cases which have done nothing. And for years, they've been persisting with the fluid. The fluid is there, vision is 6.6. The other eye develops neovascularization, it's gone down to 6.24 or so. But both are staying stable now. So you can have, we see a lesion and we say treat. Every lesion may not need treatment. This is one aspect. The second thing is, we are talking of ICG changes in hyperpermeability and tortuosity and everything. The point is, how many cases do we have where we've done normal ICGs? And what is the normal variation in the ICG in terms of caliber of the big choroidal vessels? Because my feeling is, we are only doing it in diseased eyes. So when we do them in diseased eyes, look, this is tortuous in that area. The question is, can you have that tortuosity without the disease? And we don't actually have.
Unfortunately, sir, this is going to be a very difficult thing to do.
No, but I'm saying till then we are sort of jumping the gun. That's all I'm saying.
Yeah. We need a nomogram there. We don't.
We
don't have those nomograms.
We'll have the discussion in further talks as well. Sorry about that, but we are a little tight on time. So, and for the next talk, I'd like to invite.
Go ahead.
Yeah, so I'd like to invite Dr. Dilraj Grewal. He joins us from Duke Medical School in the US. He is well known in the retina community. He has done a lot of work on medical retina and in the field of AI as well. Dr. Dilraj, over to you. Your topic is neovascularization pachychoroid. Let's.
Thank you so much, and hello to everybody. Hello, friends. Thank you to the AIOS and particularly to Abhishek and Piyush for the invitation to present today. And so far, we've had great lectures by Ani and Alex. So my topic assigned today is to talk about pachychoroid neovasculopathy. So as you all know, since Bailey described this about 12 years ago, we have increasingly recognized this as a distinct entity. And as you've already heard, there's basically thickened choroid with pachy vessels that leads to choroidal vessel hyperpermeability. And that associated with typically type 1 macular neovascularization is called pachychoroid neovasculopathy. We've also just had a wonderful discussion about the importance of venous stasis. And there's thought that anastomosis between the vortex veins leads to dilated and hyperpermeable pachy vessels. And then there's potential for obstruction of the choriocapillaris and potential choriocapillaris ischemia that may lead to the development of these macular neovascularizations. Animal models have also shown that you can actually induce features of pachychoroid by suturing the vortex vein, again highlighting the importance of the anatomy of the venous system in this disease. And why is this important? Because we know from several papers that there's about 4 to 5, potentially higher percentage of patients who are having presumed neovascular AMD but actually have pachychoroid neovasculopathy. So how do these patients typically present? You'll often see the pachychoroid with dilated outer choroidal vessels, as we have seen from Ani and Alex's talks. You'll often see the shallow, irregular RPE detachments. ICG may show choroidal vascular hyperpermeability around the fovea without often a distinct foci of leak, also on the fluorescein angiogram. And if you perform an OCTA, you'll typically see the net, which is often type 1 lesions. It's important again to pay attention to the choroidal vasculature. And we know that normally the superior and the inferior vortex veins are symmetric and they are separated by a horizontal as well as a vertical watershed zone. We've seen that in central serous retinopathy, there's an asymmetric dilation of the superior and inferior vortex veins, and there's typically a loss of this watershed. And that leads to anastomosis, which can occur at any location like we just discussed. And that's highlighted by the green vessels here. What happens in pachychoroid is that neovasculopathy is in addition to the anastomosis, you start developing neovascular membranes at that site of anastomosis. And then finally, you can get a spectrum of polypoidal choroidal vasculopathy or pachychoroid aneurysmal type 1, where you have these aneurysmal dilations at the tip of neovascularization. So again, we discussed the importance of having nomograms for normal anatomy, but we do know from limited literature that they are normal watershed zones, and you can see the ampulla of the vortex veins are typically symmetric. In pachychoroid and pachychoroid neovasculopathy, you'll often see dilation of the vortex veins, which are predominant in one quadrant. And so very asymmetric dilation. So for example, in this case here, you can see again the irregular RPE detachment on OCT, again, absence of distinct leakage on the ICG, and then on the wide field ICG angiogram, you'll see the predominant superior temporal quadrant with dilated vortex veins. So again, we also recognize that when groups have gone back and reclassified their patients who were diagnosed initially to have neovascular AMD, a significant portion of them, particularly in the Asian populations, for example, this paper out of Tokyo, shows that these patients actually have pachychoroid neovasculopathy. And this is important because we're increasingly recognizing this. Similarly, if you look at the OCT angiography features, we are now recognizing that these pachychoroid neovasculopathy eyes have macular neovascular lesions, which are typically smaller and also less complex as compared to those in neovascular AMD. And that can be assessed by the maturity of the macular neovascularization, as well as different imaging parameters like intersection points and fractal dimensions. We all know that it often takes a combination approach of anti-VEGF and photodynamic therapy to manage pachychoroid neovasculopathy. But it's also important to recognize that just like we beautifully heard Alex illustrate the spectrum of the non-neovascular complications of pachychoroid, that there's a disease continuum for pachychoroid neovasculopathy as well that can then progress into polypoidal choroidal vasculopathy or the pachychoroid aneurysmal type 1. And in this paper, you can see that there are 3 examples here where the patients were followed longitudinally and went on to develop these distinct polyps that can be seen on the OCT as well as the ICG angiography. And again, the thought here is that this chronic choroidal congestion leads to increased perfusion of these type 1 macular neovascularization, which over time, that increased flow can lead to aneurysm and polyp formation. We are also recognizing that eyes with this type of a pachychoroid PCV are typically younger. They're more likely to be males. They have fewer typical AMD-like features, more CSC-like features, and they often have a poorer response to anti-VEGF than the non-pachychoroid spectrum of PCV. Again, looking at some of the OCT features that are helpful is the tall peak PED, which is often more than 150 microns in height, and the presence of subretinal hyperreflective material in addition to subretinal fluid. We have also recognized the importance of scleral thickness as a risk factor in addition to the choroidal thickness. There has been recent data showing anterior segment OCT having a significantly thicker anterior sclera in pachychoroid neovasculopathy and CSC as well. And we know from the other end of the spectrum, the extreme end of the spectrum, that is uveal effusion syndrome, that they have a thick and a glycosaminoglycan-rich sclera. And the thought is that the penetration of these colloids have led to the retention of this material in the choroidal interstitium as well, fluid accumulation, and then choroidal thickening. In addition to that, there's also a potential mechanical effect from this thick sclera, which compresses the vortex veins that drains the choroid and then again leads to this backflow into the venous system. And this has led Bailey-Freund's colleague, Dr. Rick Spade, to coin the term overload choroidopathy. So what about the fluorescein angiography findings in pachychoroid neovasculopathy? Some groups try to distinguish the findings and say that there can be a spectrum where there's CSC dominant type, where you can get these distinct pinpoint areas of leak. Like Dr. Talwar mentioned, that there's often micro areas of RPE that are sick. These can sometimes resolve spontaneously too, but over time they can lead to breakdown of the blood-retinal barrier and then exudative changes. And again, you can see a good response after 3 loading doses of aflibercept and then half dose photodynamic therapy. In contrast, there can be a phenotype which is predominantly characterized by the macular neovascular membrane with increased leakage seen on the angiogram. And these patients often have this double layer sign or the shallow irregular pigment epithelial detachment. And while the response to combination therapy is often good, due to the higher prevalence of macular neovascular membrane, there can be a recurrence. We have typically been taught that if the response to anti-VEGF treatment is inadequate, then the addition of photodynamic therapy is very helpful. As you can see here, after 5 anti-VEGF treatments in the middle OCT, there is inadequate resolution of subretinal fluid, but that responds completely after photodynamic therapy. But now that we have faricimab and 8 mg of aflibercept available, is it potential that we may have a better response with anti-VEGF monotherapy? We are getting some answers from the Salveen trial for polypoidal choroidal vasculopathy, where up to 80% of patients have absence of retinal fluid by week 16. But more importantly, majority of the polypoidal lesions were either closed or inactivated at week 16 with faricimab monotherapy. So it'll be interesting to see how the outcomes are with these newer anti-VEGF agents. I personally don't have experience with brolucizumab, but it has been demonstrated to be very effective, again, for controlling the fluid, and there is some thought that potentially the higher osmolarity may have a role to play in the superior drying effect that is seen with brolucizumab. It's also important to recognize that the macular neovascular membrane itself, as evidenced on OCT angiography, may actually enlarge after treatment. So in the top panel, that is treatment-naive pachychoroid neovasculopathy, and the bottom panel shows resolution of exudation after 3 injections of aflibercept and then half-flown PDT. But you'll see that the OCT angiography shows that the macular neovascular membrane has actually enlarged. And this is important, again, to highlight that we should not be using the size, area, or dimensions of the macular neovascular membrane or OCT as an outcome of treatment response. We are also recognizing that there are increased angiogenic cytokines like VEGF-A and placental growth factor in pachychoroid neovasculopathy, and decreased pro-inflammatory cytokines like IL-6 and IL-8 in pachychoroid neovasculopathy compared to CSC. again highlighting the importance that anti-VEGF plays in treatment of this disease, and then the potential for better response with the newer agents. We have very good data showing that long-term photodynamic therapy outcomes, particularly with half-fluence PDT, have been very effective with no increase in RPE or macular atrophy seen at 3 years, even post-combination treatment. And you can see here that even after the treatment was delivered initially, there is continued reduction in the choroidal vasculature and remodeling that continues to take place, as evidenced by a reduction in choroidal vascularity index that takes place up to 3 years after treatment. Again, we have seen that the choroidal thickness itself reduces with treatment, and this is showing that the fellow eye choroidal thickness remained stable, whereas the treated eye continued to experience a decline in choroidal thickness up to a year after the 3 initial loading doses of anti-VEGF treatment. So with that, I would like to thank you for attention and open this up for discussion.
Thank you, Dilraj. Especially the last few slides were quite enlightening, as to the changes with time that happen with or without the treatment. Now, going back to one of Dilraj's slides where, he mentioned that when researchers went back and saw their cases of AMD, they were able to classify almost 40-45% of their patients as not being the classic AMD, but actually Pachy-associated neovascularization. My question to the panel, Dr. Chaitra, should we be looking at our cases of macular CNV in our population? I mean, should our thinking be that if it's associated with a choroid that is thicker than usual, then we call it as a pachyneovascular disease and treat it separately, or have a different consideration compared to when you have a normal or a thinner choroid? So should we be calling AMD as the classic as associated with a choroid that is not thickened, and we should be calling those that are associated with a thickened choroid as pachyneovasculopathy, and should not be calling it as AMD at all?
So, Abhishek, in the clinic, we're really not looking that much into the details of, how each one of them present. At the end of the day, we're only looking at how best we can treat most of these patients. So frankly, I haven't really gone, and Dilraj's slide was quite interesting when he showed how different the maturity of the vessels are. It's very different. So maybe going forward, we'll see. And I think what is going to be more interesting is to see if there's a difference in the treatment, response to the drugs that we commonly use for these particular patients based on how their choroid is. I think that would be something that I would be looking now that this sort of literature has come out with a difference in the vessels. Then again, how to really look at them, in what imaging modalities, the kind of, imaging modalities that we have, at least the Octa that we have, is not so, high in resolution that will be able to pick up the vasculature so well. So I'm not really sure whether I'm going to clinically decide this is A versus B, because most of the management is going to be quite the same.
Yeah. I just like to add that, I think beautiful talk by Dilraj. I mean, a lot of wonderful points captured. I think one key thing to understand here when in a pachychoroid driven neovasculopathy is the key thing here is the ischemia that is happening at the satellus layer, the small, choriocapillaris layer. What's happening essentially is the turgid choroid or the pachy vessels are now impinging so hard on that satellus layer or that layer, they're inducing choriocapillaris ischemia. I think this is the key thing. In pachychoroid, we generally talk about hyperpermeability and the turgid pressure driving a lot of fluid transudation. Yeah, through that breaks, and the previous talks beautifully illustrated that. The second thing is, but what is also happening in the background, and occasionally when the RP is tough enough to prevent a focal blowout, is that the satellus layer is getting compressed. Now what is going to happening is there's a lot of ischemia there. VEGF factors are released, and what you're now having is the pathway of neovascularization. So it's a different entity that is coming into play, and very often these cases will have that double layer sign. In fact, almost always, as Dilraj beautifully shown, that you're going to have that rippled RP lifting up, and there's going to be some ischemia there, and you're going to now have some irregular frown of neovasculopathy there, and these will respond a little better to the anti-VEGF compared to per se your PCV-driven polyp. So what I'm trying to say is that in your regular choroidal, pachychoroidal disease, while we are talking about the adjacents and the fluid overloads, whereas in this particular subset, it is the ischemia which is the key thing. And that is why in today's world, I mean, these years, choriocapillaris ischemia and the study of choriocapillaris is becoming a very dominant area in this field. Yeah.
Just
Yes,
one
first
last
of all,
question to Dr. George. Yeah, so I
just
have a
want
question
to
for you, Dr. George.
add a point.
Maybe Abhishek, we are shooting time, so
Yeah.
perhaps we can discuss this a little later.
I think so,
Just a quick.
because we are already very much
Yeah.
late
No,
in time.
very beautiful talk by the speaker, Dilraj, and he has actually pointed out the importance, because we never used to look before we had swept source or EDI. Only at these, that's when we started. And Octa is so important in this. Without Octa, even with fluorescein and ICG, many a time we miss this. So that is why we are diagnosing most of these very subtle neovascularization, which are obviously smaller compared to the other regular networks. And he had raised a point in his slide whether the newer anti-VEGFs are more effective in this. Yes, it is. It is definitely. It has been shown that aflibercept and even brolucizumab, even penetration is better, and even the choroidal thickness itself reduces. But then when you combine with a PDT, you have best of both the worlds. Even the choroidal turgescence, which Anand was mentioned, that is being taken care, and plus the anti-VEGF. If you don't combine, I have even had a patient where chronic CSC, it was mistaken, and then PDT, but then the CSC part, but then again the patient presented with that active neovascularization. So we need to combine anti-VEGF with PDT. That would be the best option here, I think.
So,
Right. Thank you. Thank Judge.
Yeah.
So
we'll move on to the next talk. The next talk is by Dr. Nopasak Fasukijavatna. He joins us from Thailand, and I'd love to welcome you, sir, to this meeting. And he's going to be talking to us about the Pachychoroid Vitelliform maculopathy.
Just to add, Dr. Nopasak is Associate Professor in the Department of Ophthalmology. He's in the Faculty of Medicine in Siriraj Hospital in Mahidol University in Bangkok, Thailand. And he'll be talking to us, like Abhishek said, about Pachyvitelliform maculopathy. We can begin, sir. Yes, we can see your slides.
Sir, please unmute yourself.
Okay. Can you hear me now?
We can hear you.
Okay, thank you. So good evening, everyone. I would like to begin by thanking the organizing committee for these opportunities. It's both my pleasure and honor to join you today. The topic of my presentation is Pachyvitelliform maculopathy. So let's begin with the case. The patient is a 75-year-old Thai man. He is the father of an ophthalmologist who was referred to me with a complaint of blurry vision in his left eye. On examination, the left eye revealed macular alveoli with macular edema, which explained his symptoms. However, in the right eye, an abnormal yellowish subretinal lesion was observed in the parafoveal area. The lesion in the right eye exhibited hyperautofluorescence consistent with a vitelliform lesion. Additionally, motile autofluorescence was observed in the infranasal macula of the left eye. His daughter, who is an ophthalmologist, expressed concern about the parafoveal vitelliform lesion in his right eye because it's close to fovea. What is the diagnosis? We will return to this case later. There are numerous differential diagnoses of vitelliform maculopathy, including Best disease, acute exudative polymorphous vitelliform maculopathy, paraneoplastic, MEK inhibitor-associated retinopathy. However, the patient history and clinical presentation did not align with any of these conditions. Other more common causes to consider include tractional changes, AMD, chronic subretinal fluid in CSC, and even in peripapillary pachychoroid syndrome. However, the fundus finding was not consistent with these conditions either. At our onset, foveal macular vitelliform dystrophy could still be included in the differential diagnosis. Additionally, a recently described novel entity, Pachyvitelliform maculopathy should also be considered. This new entity was just published by Dr. David Saraf in BJO last year. Pachychoroid is not just a thickened choroid. It involves several associated features, as many speakers has told. Pachyvessel choroidal hyperpermeability. Perhaps the most significant is the presence of pachyvessels, which are dilated vessels in the Haller lab, occupying nearly the entire choroidal thickness, compressing the inner choroid and the choriocapillaris. The pachyvessels co-localize with the overlying retinal abnormalities, and many times you can see pachyvessels in a choroid of normal thickness too, just like you see in a PCV case on the right hand. Pachyvitelliform maculopathy was initially described in a series of 17 cases where acquired vitelliform lesions were found to overlap pachyvessels. Other potential causes of acquired vitelliform lesion were excluded. The patients were quite in older age, typically in their 70s, and maintained relatively good visual acuity. Subfoveal choroidal thickness appeared increased for their age. However, after several years of follow-up, visual acuity declined, which was associated with progression to RPE atrophy in about 40% of cases. These are images from the paper illustrating acquired vitelliform lesion overlying pachyvessels. Over the first few years, the lesions appear to enlarge. By 6th year, the vitelliform lesion had resolved and leaving behind retinal pigment epithelium atrophy. You can also see the choroidal hyperpermeability on ICGA. This slide shows the proposed pathogenesis of Pachyvitelliform maculopathy. Because we see in older age-related degenerative change, combined with pachychoroid-induced alteration in the choriocapillaris, can result in choriocapillaris ischemia. The ischemia leads to RPE dysfunction and impaired phagocytosis of shed outer segments of photoreceptors. Consequently, a subretinal vitelliform lesion develops, and it may serve as a marker for progressive RPE dysfunction and breakdown. Now let's return to our case. In the right eye, a pachyvessels observed beneath the vitelliform lesions, even though the choroidal thickness appears in normal range. On-fast OCTA of the choroid clearly demonstrate the co-localization of the pachyvessels with the vitelliform lesion. Therefore, we think that this is pachyvitelliform maculopathy. In the left eye, there are some motile autofluorescence and correspond to the area of ellipsoid zone disruption. And you can see pachyvessel underlying beneath the ellipsoid zone disruption. And I think that this is pachychoroid pigment epitheliopathy, even though the total choroidal thickness is not so thick. The patient was followed for 5 years. In this registered OCT scan, the vitelliform lesion appeared to have enlarged over time. In another scan taken more superiorly, the vitelliform material had resolved, leaving behind RPE atrophy. So in summary, pachyvitelliform maculopathy is an additional member of pachychoroid spectrum and represent a novel differential diagnosis for acquired vitelliform lesion. A significant proportion of patients eventually develop RPE atrophy. Recognizing this entity is important to identify the cause of vitelliform lesion. Thank you very much.
Thank you, Professor, for taking us through this new entity. And I would like to open it up to the panel, to our expert panel regarding the same.
I think it was a very interesting new thing, but
Yeah.
what seems to be is it possible? And that's the question I'd like to ask you. Great presentation. Could it be that this is a correlation that we are finding? That when you have a Vitelliform change and you have a pachychoroid change underneath that area, then the prognostic it's a prognostic indicator that over the next 5 years or so, you can expect it to cause some vision loss. Maybe slow vision loss, but it can cause vision loss. And if you don't have it related, the Vitelliform change may be an incidental finding, but when corresponding to the choroidal change, it makes it a little more potent as a negative prognostic factor. Could that be the thing? Or do you believe that the pachychoroid caused the Vitelliform?
I think the fact that the Vitelliform lesion is co-localized so nicely with the pachyvessels, I think pachyvessel may cause the Vitelliform lesion, in my opinion.
Can I ask you one question? Did any of these patients progress to macular neovascularization over time?
I don't have that answer because in the paper they exclude all the macular neovascularization and any evidence of subneural fluid. They all exclude.
No, I'm not talking about exclusion. I'm talking about the presence of the Vitelliform lesion, the Vitelliform lesion disappearing, RP atrophy. I mean, and ultimately the pathogenesis is a pachyvessel and a thick choroid and inner choroidal ischemia. Therefore, the processes are the same, and therefore, whether any of these patients did progress into a macular neovascularization over time. There is no answer to that.
I don't have answer to that actually, but in my experience, I don't see patients with the Vitelliform lesion progress to devascularization.
Giridhar sir, I think this is a small subset of patients, and there is no. I don't think it has a evidence of neovascularization.
It's more of a imaging finding rather than. I mean,
I just like to correlate this to what Dr. Papnis just mentioned, Dr. Alex, that there's a small subset of patients where the disease is in the RP. I think this is an abnormal reaction of the RP to the pachyvessel pressure, continuous pressure. So as we've seen, most vitelliform diseases are diseases of the RP. All the acquired diseases as well as the congenital ones. So it's a manifestation, it's a reaction of how the RP is reacting.
I agree with Dr.
Continuous pressure,
Anand. Dr.
Pachyvessel.
I agree. Yeah. I think probably the same irritation that caused the epitheliopathy is causing the irritation, but the phenotype of this particular RP is such that it leads to accumulation of the vitelliform material rather than its clearance. And that causes this kind of a lesion.
So initially there is an outpour of vitelliform material and then it dies down as atrophy.
Right. So we'll move on to the next part of the session, which is made of interesting cases that are going to be presented with a bent towards the pachychoroid spectrum. They all have something related to the pachychoroid. And we're going to start this with Dr. Darius Shroff, who joins us from Delhi. He is the medical director of Shroff Eye Center and is a prolific VR surgeon. Dr. Darius.
I'd like to thank Abhishek and Dr. Piyush for this opportunity. Can you see my slide?
We can see your slides, and just one more addition to all the cases. We'll have to stick to the time because we have 3 minutes for case and just 3 minutes for discussion. We've already overshot significantly. Over to you.
I think I only have four slides, so I won't take time. I'll just start off. So this was a lady who presented to us in 2016. And she was 81 years old, and she came with blurred vision in the left eye. And vision was 6/9. So what do we see? We see the yellow arrow showing a PHCR. So disclosure from me is that PHCR is like my pet disease. So there's a PHCR, peripheral exudative hemorrhagic chorioretinopathy lesion here. And when we do the FFA, we can see some CME at the posterior pole, and that's seen on the OCT also. You can see some cystoid macular edema and a neurosensory detachment. So this is a case of PHCR with CME. So what do you do? And what I want you to emphasize is there was no CNVM here. The RP is absolutely straight. So she's had a huge amount of anti-VEGF injections over 9 years and has irregular follow-up. And you can see that we give her injection, the CME goes away, she comes back after some time, and the CME persists. But this is where I want you to hold your breath. This was not an isolated phenomena. When I started seeing more and more of my PHCR cases, we saw it in many. I discussed it with colleagues, and my friend Dr. Ritesh Narula also said he had, I think, 2 cases of that. So this is something which has just come out in the Indian Journal of Ophthalmology in January 2025. Cystoid macular edema as a manifestation of PHCR. So this is something which is quite interesting. If you look at the patient here, you see that hemorrhage thing in the mound in the periphery, temporal periphery. You see the CME. Give anti-VEGF. The PHCR lesion gets fine. It's cast down, and the CME goes. This is the same patient. You see the PHCR lesion. You see how it goes away with anti-VEGF. The OCT looks beautiful. The lesion is also gone down. So this is something which we've just reported. It's some new information. I don't know whether the panelists have experience of seeing CME exclusively in PHCR. How does this all kind of rope into pachychoroid? I'll explain that to you. If you see her periphery, you can see beautiful polyps on the ICG. And you have the white field ICG, and of course, you can see the CME at the posterior pole. So this is what got me interested, and you see the way the choroid is. The choroid is thicker in the periphery and thickest under the lesion. When I saw this kind of a choroid, I discussed with Jay Chablani, also one of my friends, and we realized that normal choroid is bowl-shaped. It's like a bowl, a katori. Under the fovea is the thickest. But in PHCR, we are seeing club-shaped or clabate choroid. The choroid is thick in the periphery and becomes thinner. In fact, what was just discussed, peripapillary pachychoroid, it's like the inverse. In peripapillary pachychoroid, you get thick choroid at the disc, and it becomes thin in the periphery. And PHCR is just the opposite. You have thick in the periphery, and it comes thinner in the center. So this is just some graphs from the retina article showing the kind of contour which is there. And the patient also had the same contour. So this is my last slide. She just came last month. It's getting regressed. The CME comes back. We advise her injection. She makes faces at us. She gets it after a month, and she gets better. So the take home from this is that in elderly patients with CME, don't miss checking the periphery, because it could just be some lesion lying in the periphery, a large PHCR lesion. But I open it for discussion.
It's a wonderful case series. So we do see cases of these kinds, but as you rightly pointed out, is that the cystoid macular edema component is not something that we see very frequently, or probably not much. So anybody else has any experience of?
Good
I have
finding.
patients with CNVM along with this. That means there's a central component and a peripheral component.
Yes.
The central component is treated with anti-VEGF. And actually, I discussed this with Darius also. I actually very often have done peripheral 360-degree laser, then followed up by local laser of those lesions to completely destroy that. Then the periphery thing doesn't come back. Once you do that laser, it doesn't come back. If you don't do the laser, you have to keep on giving injections in the middle.
I agree. I have a similar couple of cases where in one there was a CNVM, of course, but when you have these peripheral polyps, it's eventually you end up lasering them, and they've been stable for the last couple of years.
Very, very interesting finding, Daras, because I'm yet to find a patient who had this recurrent CME in PHCR. We get, other findings of PCV, but
I think the problem is, George, we probably don't do OCT in some of these patients, especially when we treat peripheral lesions. We are looking only at the periphery. We probably may be doing the OCT the first time, but subsequently we are only looking at the peripheral lesions. So we are only treating them.
Yeah.
And ICG probably is used more often. And therefore, probably we are missing.
We have the OCT, sir, but then this is very peculiar.
Yeah.
And actually, one case had only a macular CSR, and I have actually shared with Darius that patient on peripheral examination had a PHCR. Patient had just presented with a CSC and had a PHCR in the periphery. So basically, that correlates because both are pachychoroid diseases.
I told Dr. George that's the missing
George,
link.
is it
That's the
possible
missing
that
link
was
you found.
pachychoroid only, and that was actually a very early pachychoroid in the central area, with more with a more advanced form of the pachychoroid, which is the PEHCR in the periphery. So actually, you were seeing
there is no
and
polyps
the
or
other thing
anything
I'd like
at
to ask
the
Darius.
macula, only just a simple CSR at the macula, but when seen the periphery, ECG showed polypoidal lesions.
Yeah, I
Darius,
think
what I'd
all of
like
us
to
have
ask
seen
you, was this
CSR with PHCR, but the CME, I think that possibly is a reaction to a lot of irritation of a large tract of RP, which is caused. So I think it's two different things. If it was a pachychoroid driven thing, you should have seen a thicker choroid under the fovea. But this is a totally different reaction. So all of us have seen, and PHCR usually manifests as hemorrhage and other stuff, and we do a vitrectomy and you see a big PHCR lying there. I think all of us have seen all that. But I think this specifically is the widespread irritation of the RP all around, leading to this reaction. And that's how I think
Dr. Anand, could this be also why, like in melanomas, also people have reported CME in melanoma? So this is exactly what you're saying.
The Shields group has mentioned a recent publication 23 CSR in choroidal melanoma. So that of course is a backstasis pressure, and they've even said melanomas masquerading as CSR. That's the title of the article. So this, I think, is just a widespread irritation and in a degeneration there, which is something like your Irwin gas kind of thing. There's some inflammation happening because of this widespread irritation of the RP. That inflammation is driving the CME. Because if you see your pictures very clearly, there is hardly any thickening of the choroid under. And your nomogram also shows that. So it's an irritation, inflammatory driven CME.
Darius, have you done
We'll move on to the next case.
Let's
We'll
move on to the
next
next
case in the interest of time. So we're very short on time. I'll ask.
You message me, Dr. Talwar sir, message me.
Yeah, we'll take it up later. We have Dr. Anubhav Goel, who's a VR consultant at Giridhar Eye Institute in Kochi, who's going to be sharing an interesting pachychoroid case.
Yeah, thank you, sir, for giving me this chance. Are my slides visible?
Not yet.
Not yet. Yes, we can see it. If you can maximize it, please.
Now maximized. Is it
yes,
visible?
we can see your slides.
Yeah. So, 1 second. Where is it gone? Sorry for this confusion. Yeah. So good evening all. I'm presenting an unusual case, uncommon case of choroidal vascular abnormality. So this is a 66-year-old male who has a long-standing defective vision right eye, but he came with defective vision, recent onset defective vision left eye, right, with 6/9 and 6 vision left eye, but right eye was having 660 vision. So if you see, right eye was having already foveal atrophy, but left eye came with he presented with the left eye with fibrovascular PD. Autofluorescence on right side is not showing any significant autofluorescence changes. So since the retina was not showing any intraretinal edema in multiple sections also, we just followed up this case. And after we did ICG of this case at that point of time. And if you see, we observed a abnormally dilated and tortuous choroidal vessel, which is temporal to the macula, extending from the center of macula till the temporal periphery, which was an unusual finding in addition to the dilated choroidal vessels coming from the vortex vein all around it. And these are sequential CG images of over the time. And if you see on the magnified view, this is a very widely dilated abnormal and tortuous vessel, choroidal vessel temporal to the macula. All the vortex veins were enlarged in all 4 quadrants, both the eyes, which is more prominent in the left eye as compared to the right eye inferior quadrant. Angiogram, fluorescent angiogram was not showing any significant changes over the time in the left eye. And to our surprise, after 3 months follow-up, patient came with complete resolution of fibrovascular PED and there was no change in vision, but patient was symptomatically better, so we kept him on follow-up. But we repeated the ICG that time. That time, if you see that abnormal vessel got little bit more prominent and more tortuous as compared to the last visit. 1 week later, patient came with sudden decrease in vision, and there was a rip. You can see prominent thickening RP with subretinal fluid and temporal to the rip and in the subfoveal space, and autofluorescence also showing classical rip. But luckily, it was just juxtafoveally, so vision was 6/9. So we started treatment at this point of time because patient was symptomatic at this point of time. He was not much symptomatic or asymptomatic before that. We started with aflibercept in a loading dose, and after the third loading dose, you see there was complete resolution of fluid along with this decrease in RPE thickening. And the third ICG on this visit was showed that significant reduction in that prominent choroidal abnormal prominent vessel or temporal to the macula. This time, patient was continued follow-up, and 2 months later came with recurrence of SRF and given more injections. So last visit patient has seen dry fovea but small streak SRF temporarily. So these are the sequential ICG follow-ups images done in March, then June, then September, then December. You can see this vessel was prominently dilated, much more dilated and tortuous in compared to before and after the images, and this was just before the starting of treatment. After starting treatment with anti-VEGF, this vessel has actually gone less prominent. And if you see, there was a abnormal, this vessel is continuing with that dilated choroidal vessel, and this is continuing with the retinal vein in this. So it is a abnormal venous connection of the choroid with the retina, which was seen more prominent after the starting of treatment, probably after the regression of the fibroscular PD. So my question to the panel is it a venous overload choroidopathy, or is any experience observing such abnormal venous complications in the panel? And how do you treat this case, or how will you do considering laser to this veno-venous anastomosis will help in this case or not?
Behaves like a wrap, this one. It's like a retinochoroidal anastomosis.
Yeah, it's a retinochoroidal. But the thing is, I mean, this is my patient actually, and I presented this in other meetings also. But I've been doing ICG for the last 20 years. So I've never seen a choroidal vascular abnormality like this. I mean, I never seen a choroidal vascular abnormality. I mean, even if it is a wrap, I mean, ultimately it's something like a wrap, but I mean, that sort of a dilated vessels, I mean, coming from the temporal side and a bunch of them coming to, I mean, I've never seen something like this, although I've been doing, ICG for more than 2 decades. So that's what was very, I thought that this is something very unusual. And
the other eye was wet AMD, is it, sir?
The other eye, unfortunately, the other eye also has got a similar picture. The other eye also has got a significant choroidal vascular abnormality, but unfortunately, because the fovea, that area is scarred, we are not able to demonstrate some of them. But the other eye also is having this sort of a dilated vessels in the temporal portion.
Other eye was having more of punctate hyperfluorescence on the ICG, sir, rather than that unusual dilated.
But there are, I mean, that's also having a vortex vein abnormality.
Yes, abnormal vortex abnormality.
Right eye, does it have a neovascularization, sir?
I think he must have had, because he has a submacular scar.
Because your ICG in the left eye do not show a neovascularization in the
Yeah,
PVD.
exactly. There is no neovascularization.
But that's early phase, no? That you won't see it in the early phase.
Even in the late phase, in this patient.
You have an OCT angio also.
Yeah, OCT angio did not show anything, sir. OCT angio.
What seems to have happened was he got a micro rip, because of which the RPED collapsed.
Yeah.
And the micro rip then progressed to a full-fledged rip, which is what caused the subretinal heme.
Yeah.
But if you see the last ICG, it is not that the vessels disappeared. It is just that it has been obscured because of that rip area.
Yeah.
Part of this thing. It's not gone away.
Yeah. No, the RP rip has occurred because of a sudden gush of fluid in the subretinal space. It's a sudden gush of fluid. It's not a fibrovascular PED that is ruptured. It's a sudden gush of fluid that has just come
collapsed
into space and that just ripped.
Yeah.
So
what is
So I think
we'll move on to the next case, sir. I mean, we can theorize, but in the interest of
no, I
time,
think
already getting
just one word.
last quick comment, George.
Giridhar sir, it is a drusenoid PED because there is a sub-RP hyperreflectivity on OCT.
Exactly.
In a evolving drusenoid PED, they can have subretinal fluid, and we also have seen a drusenoid PED evolving and developing a rip also. So whether that choroidal tortuosity is a very significant finding, but then whether it's unrelated to the rip of a drusenoid evolving PED is what
no, but actually anyway, that drusenoid PED had collapsed.
Yes, so I think the rip happened. The fluid came out. It decongested that Pachy vessel.
We can have this. We can have this discussion a little later, sir, because we are absolutely running out of time, and there are two more speakers.
We actually have 3 speakers remaining, and we'll just change the schedule a little bit. We'll call Dr. Joel Perez first because it's quite late in his country. I'm sure it's around midnight. So, Dr. Joel Perez, could you load your slide, please? He's a medical retina consultant at the Makati Medical Center in Philippines, and
let me just share my slides.
yes, we can see your slide if you can maximize it, Dr. Perez.
Okay, hi, good evening, everyone. I would like to thank the organizers for this opportunity to share this interesting case. So let's proceed with the case. We have a 76-year-old male complaining of a recent onset of blurring of vision on the left eye. However, has had long-standing blurring of vision on the right. Patient also has a history of occasional use of topical steroid cream for his eczema. Vision on the right eye is 6/60, and on the left it's 6/9. And posterior findings show an atrophic patch on the right fundus, and on the left we see some shallow elevation at the central macula. OCT scan of the right eye shows degenerative cystic changes, ellipsoid zone disruption, and RPE atrophy. We see a thickened choroid and some Pachy vessels over here. Unfast OCTA of the right eye, incidentally showing macular neovascularization as well. And the choriocapillary slab of the unfast OCTA showing a suspicious flow impairment at this area. The left eye, we see subretinal fluid. Again, we see a thickened choroid with some Pachy vessels. Unfast OCTA is negative for any neovascularization, and some suspicious area of flow impairment at the unfast OCTA. So our working diagnosis is left CSR on the left eye and the pachychoroid neovasculopathy on the right eye. The management for this patient will be focused on the left eye due to the poor visual prognosis of the right eye. So we discussed with the patient to just observe for now and to stop self-medicating with the topical steroid cream. But the patient was lost to follow-up and comes back 9 months after. The vision on the left eye has decreased to 6/12. We see persistence of subretinal fluid with some areas of hypertransmission defects on the OCT. We wanted to be a bit more aggressive in the management of this case, so we wanted to see if we could do focal laser for this patient. However, looking at the fluorescein angiogram of the patient, the area of the leak is quite proximal to the fovea, so we didn't want to cause any inadvertent damage to the fovea, so we deferred that plan. And another thing, we did autofluorescence at this time. We see a granular hypoautofluorescent changes and some gravitational tracks, which is suggestive of the chronicity of this case. I would have done PDT to this case. However, we don't have access to PDT in our institution. In the Philippines, it's actually quite inaccessible. Focal laser is not possible in this case. So we decided to proceed with spironolactone therapy. The patient started with 25 milligrams per tablet BID. However, 1 month after starting spironolactone therapy, he could not tolerate the systemic side effects, so he discontinued taking spironolactone. Vision at this time was again 6/12, and there's still persistence of subretinal fluid. At this time, the patient was quite anxious because this was his only seeing eye, and we were running out of options. So we discussed the possibility of a trial of anti-VEGF with this patient. We were getting a bit frustrated with the management of this case, and we were kind of hoping that there was some hidden neovasculopathy that we weren't able to see in our workups. So the patient proceeded with anti-VEGF therapy, a loading dose of Avastin, and at this time, there was no response. So now the dilemma is, should we proceed with focal laser, or is there a role for subthreshold micropulse laser as well? So just to summarize, the treatment of choice would still be PDT. However, access to PDT remains limited in many parts of the world. And of course, future research is needed to develop alternative treatment strategies for these kinds of patients. Thank you.
Thank you, Dr. Joel.
Did you have an FFA?
Yeah. In the interest of time, I'd just like to make a quick comment, and that is, I think the focal laser was possible. The point of leakage looked a little away from me, and especially in this case where you don't have too many options. In our country, also PDT is not available, so a careful laser could possibly, help in this particular patient. We'll move on to the next case by Dr. Shishir Varghese, who joins us from Kerala. Over to you, Dr. Shishir.
Yeah. So my slides are visible?
Yes, please go ahead.
So thank you, organizing committee, for this opportunity, and thank you, Dr. Piyush. So I'll be talking on extramacular PCV. So no financial interest. So I'll discuss the first case. So this was a 60-year-old male who presented with for a routine follow-up. Best corrected vision was 6.6 in both eyes. Now before this history, he initially had come 1 year back, and as you can see, he's got thick choroid in the left eye, and then he's got a small pigment epithelial detachment just about superior to the fovea there. So this was the OCT angio done at that point of time, and we can see there was an RP irregularity, and an OCT angio through that area shows the presence of a small neovascular network. So this was like a subclinical CNV. Now currently, so this was his current fundus photograph. Right eye has an ERM, the left eye is seen this grayish whitish lesion just temporal to the fovea there, and some area of little more graying, even more temporal to that. And this was the autofluorescence showing hyperautofluorescence temporal to the fovea with some granularity in the center. And this was the current OCT, and you can see he has developed a small subretinal fluid along with that hyperreflective pigment epithelial detachment. And underneath that, you can see the dilated choroidal vessel, or the dilated, Pachy vessels could be seen. So this was the raster there, a PED on top, which was like a thumb-like, along with small notches there. And then he had subretinal fluid. Vision was still 6.6. The left eye, this was the EDI, again, thickened choroids in the right eye. Thickened choroids, and this was the ICG, FFA ICG of the left eye. We can see these dilated thick Pachy vessels right at the center there, and there is some amount of hypersynescence which is happening there temporal to the fovea. And as you go, you can see that small polypoidal lesion there which picked up on the ICG. And these are the late phases of the ICG where you can still see the polypoidal lesion. So he was planned for an injection Eylea plus focal laser, which was done for his left eye, and this is after 1 year. So that's the only treatment which he underwent. And this is the fundus photo of the left eye. You can see the scarring there. This is again the grayish white area, and there is hyporeflectivity on the autofluorescence there. And this was the OCT after a year. Vision is still at 6.6. There is no subretinal fluid. There is an RP irregularity there, but the PED has also reduced in size, and it's like a scarred or fibrosed, which you can see there. And this was the OCT angio done after the laser, and at 1 year, you can see there is still a network there, but it's actually inactive with some hypospaces in between there on the OCT angiography. Now coming to the second case. So this was a 54-year-old lady, hypertensive on medicine, sudden visual blurring in the right eye. Best corrected vision in the right eye was 660, the left eye was 618. Now this was 1 year before she came with the complaint of the decreased vision. So the right eye had 6.6 vision that time. There was a PED there, and the left eye had somewhat like an RP atrophy, which you can see there on the fundus photography. And when you look at the OCT of the left eye, you can see an RP aperture, or what you call like a micro rip. So along with a little bit of a foveal atrophy, and then you can again see that thick choroids just underneath that. So this was probably like a chronic or a resolved CSC with this RP aperture, which you can see in the left eye. And that's why the vision in this eye was 6/18. So in the right eye, her vision was 6/6 that time. And again, here you can see this small RPA, like a double layer sign, what you can see there. And then there was a PED right on top of that. Now she was advised follow-up after 4 months, but then she didn't come for follow-up. And that's why she came with 660 vision in the right eye. She developed vitreous hemorrhage with a subretinal heme underneath. And there was a fresh heme and an old heme. It was just, nasal to the fovea there. So and this was the OCT raster, which you can see subretinal heme under the fovea and nasal to it, along with some, thumb-like PEDs, peak PEDs, and multiple notched PEDs just about superior to the disc on this third OCT raster, what you can see. So she was advised injection Eylea. First, she was advised 1 dose, and then just to see what happens later. So this was after 1 dose of Eylea, the vitreous hemorrhage reduced. The fovea was dry, the hemorrhage also reduced, and the PED also has reduced in size. It has slightly collapsed. As you can see there, even the temporal to the disc as well as superior to that. And then after the one Eylea, she underwent a focal laser, and after the focal laser, she underwent another second Eylea because she still had a little bit of vitreous hemorrhage. And you can see the complete collapse of the PED, and there's a little bit of scarring or fibrosis there, just nasal to the macula there, and just above the disc also the PED has collapsed with some scarring. So this is after 9 months of the 2 Eylea and the focal laser. You can see vitreous hemorrhage is completely resolved. Vision has come back to 6/6. There is fibrosis above the disc. The PEDs have been, the polyps have been lasered, and these are the residual RPE changes what you can see. And this is the current OCT again, which shows the fovea is dry, and there is a collapse of the PEDs, as well as there is a little bit of shallow. This double layer sign is still persistent, and she's currently on follow-up every 4 months. So main highlight of this, close and long follow-up is required for these cases. Anti-VEGF and focal laser for extramacular PCV is definitely recommended. It can be either ICGA or OCT guided. And whether do you have any particular protocol or whether you need to personalize for each patient?
I think, yeah. So,
Thank you.
Thank you, Dr. Shishir, for these cases, interesting cases. Yes, we do require an extramacular PCV, especially focal laser, of course, has a very important role in curtailing the number of anti-VEGF injections that are required. And if you just go along with the anti-VEGF injections, usually is a much longer journey for the patient. I would quickly like to ask Dr. Ashish Markan to present his case, a very interesting case. So Dr. Ashish joins us from Delhi. And after Dr. Ashish's talk, we can have a discussion on the last 3 cases, quick discussion. Dr. Ashish, please go ahead.
Very good evening to all. So thank you, Piyush sir, for this opportunity. Hope my slides are visible.
We can see them, Ashish. Please go ahead.
Yeah, just yeah. So I'll be presenting a patient who had a healthy retina to begin with, but then ended up into a PCV-related drastic complication, even despite aggressive therapy. So he's a 76-year-old male who presented to us in 2019. He was pseudophakic in both the eyes. The vision in the right eye was 6/36, left eye was 6/6. He had history of right eye multiple injections, Eylea for AMD. He eventually developed subretinal bleed in the right eye, for which he had underwent intravitreal TPA with gas elsewhere. So on presentation, he had this subretinal scarring in the right eye, and left eye was absolutely normal. So the patient was kept under observation. When the patient presented to us in 2020, we see that the patient had started to develop a slight elevation of the RPE. The vision was 6/6, and there was no evidence of any membrane or OCT angio. So the patient was kept under observation again. The real problems, the real problem started in 2021 when patient presented to us with a drop in vision. So OCT showed that there was an active CNVM with SRF. So we started the patient with injection Eylea. After 3 loading doses of injection Eylea, we could see that the PED is still persisting and the SRF was also persisting. Even the size of the PED was increasing progressively. So we had given an injection in month of November, but still the vision was stable 6/9, and the patient was kept on serial follow-ups. Now in 2020, a similar trend was seen in 2022. Again, the SRF was persisting. At this point of time, we advised the patient to switch to injection Paginex. But because of safety concerns of the injection at that time, and because of his vision was stable, patient refused switching the injections. So a total of 6 injections were given in 2022. And in 2023, you see the disease was more or less stable till some morphological alterations started to happen in the PED. So we could see that there were few hyporeflective areas which were developing, and there was this layering happening at the bottom of the PED, which are actually signs of progression. Also, patients started to complain of an increased metamorphopsia, though the vision was still 6/9. So an angiography was done, and right eye showed presence of subretinal scarring in the right eye, and left eye we could see that there was this stippled hyperfluorescence on FFA and a polyp on ICG in the left eye. At this moment, the patient agreed to switch to the injection Paginex in view of his increasing visual symptoms. And when the injection Paginex was given in August, the visual symptoms, they improved. But after 3 weeks of the second injection, patient presented with a sudden drop in vision and had developed a subretinal bleed, and the vision dropped to 6/36. So eventually the patient was taken up for surgery. He underwent pars plana vitrectomy with subretinal TPA injection. Post-operatively, the blood cleared, but we can clearly see that there was RP rip on the nasal aspect. And this is 3 months post-operative images. The vision improved marginally by 1 line. There's an RP rip and an adjacent subretinal scar. But the sad part is that despite aggressive therapy and patient being so compliant with the treatment, still we could not save his vision in the long run. So I would like to discuss few points with the esteemed panelist that what better we could have done to manage the case. Was it the natural progression of the disease that led to subretinal bleed? Or was it the injection Paginex, the real culprit causing the RP rip and eventually causing this subretinal bleed? Thank you.
Thank you, Dr. Ashish. Again, a wonderful case highlighting the unusual course of these kind of lesions. You can always expect the unexpected in these kind of cases. And I think, I have also shared in a couple of my presentations earlier, and so have the others, that RP rip is quite common in cases where you have a PD, even sometimes not when you have such kind of tall peak PDs, even with shallower PDs, with the newer, more powerful anti-VEGF agents, because they cause quite a sudden and predominant fibrotic kind of a reaction. You do see a subsistence of the disease, but sometimes you may end up having a RP rip as well. Thank you so much for your case. Any quick comments of the panel on the previous 3 cases, and then we can proceed to closing the session?
Abhishek, you mentioned that the newer drugs cause, faster drying and therefore the rip. So does that mean you actually change your line of management when you see these tall PDs? Because from my experience, most of them, I mean, very, very few rips I've seen. Most of them, even though they respond very well and collapse, I don't see rips that much. Not even like massive PDs. I've not seen rips in the newer drugs. So do you actually change your medication based on how large the PED is?
Yeah, I actually do. If we have a very large PED, and especially if the fovea is on one of the sides, not the center, because the rip usually happens on the sides, not bang in the center of the PED. So I am a little careful. I would probably, for the first injection, choose an agent which is which has a slightly lesser anti-VEGF action. And once the PD becomes a little shallower, then I switch on to these agents which help in drying. And actually, I've presented a couple of in a couple of meetings the use of systemic anti-VEGF as well in these cases, where I thought that an injected anti-VEGF may cause quite a bit of trouble there. So I think
it's a bit of a dicey call.
Yeah, it's a dicey call.
Yeah, it's a dicey call. See, the thing is, as Dr. Rosenfeld almost a decade ago has shown out, a lot of this. So we have seen BDs going down, collapsing, and we've had the wow effect with aflibercept first and then rolizumab. So I think it's a function of that. And this PD could have ripped even if you hadn't done anything. Just the act of putting a needle in, even injecting saline, could have ripped that RP. So I'm just saying it's just an unfortunate thing that has happened. This patient had some other clues. There was a multilaminar onion ring, that kind of thing coming in. So there was a lot
there
happening.
was already fibrosis that was
subretinally.
happening there.
Yeah. So the only thing is, if you have a notched PD if you have a tall PD with a notch and that notch is towards the foveal side, I would actually not try to burn my fingers by injecting if the vision is reasonably good. When I say reasonably good, less than 618, I mean better than 618. That is the only thing I can say. But then otherwise, it's very difficult to predict who will rip and what point of time. I think that's
Just a
just
question,
like.
could these hyporeflective areas in the PED and the layering be a predictive factor that injections could
So,
be
so
point
we
of
know
view?
that
I think
a
so,
lot of
because
that is
basically
happening because of the anti-VEGF therapy. It's
the
like a
layering.
chronic sub-RP reaction to chronic anti-VEGF. It's a tussle between the anti-VEGF versus the sub-RP events. Yeah.
Yep. So we'll go on to the last phase. Thank you very much to all the panel for the wonderful contribution. The cases were excellent. The talks were excellent. Quite crisply in 1.5 hours, we've been able to summarize the pachychoroid and the current understanding, and of course, our lack of it in certain areas. And I mean, that leads us to rack our brains every single time we have an unusual case like this. I would thank everybody. And this basically, the whole idea of the program was to give importance to the incoming and the upcoming increasing recognition of the role of the pachychoroid diseases in several of the entities, the phenotypes that we see in retina. Of course, our understanding is far from complete, and we have only started to begin to use this information as a prognostic indicator in some of our diseases, and been able to prognosticate or have some real information that we can convey to patients from our better understanding of the imaging. Hopefully, currently we don't have anything to treat the pachychoroid part of the disease, but hopefully in the near future with newer therapies, we may see something that acts directly on the choroid and can have a dramatic effect and have a wow effect, and that will help us even further elucidate our both understanding and treatment of these diseases. I'll hand over the mic to Dr. Dinesh Talwar and to Dr. Anand Rajendran for the final remarks before we close. Thank you so much to everybody for participating in this.
Thank you, Abhishek. I'd like to make just a few comments before we conclude, and I'll leave Anand to do the final conclusion. One thing which is, we've discussed the complete continuum of changes in pachychoroid disease, and it's very evident that it's not a single thing. It's not even 3-4 discrete things. It's a whole continuum which starts from one end and goes all the way to CNVM development. The second thing is we must understand our characterization is still incomplete. And I think to a large extent, that is because our understanding of ICG is still incomplete. We do not have complete normograms for what a normal ICG looks like. So when we say congested or dilated or leaking, we are actually making our decisions based on the abnormal ones, but we do not know how often do you see such a thing in a normal patient, a normal person also. But one thing which is very clear is that the stage of neovascularization where you know that you want to treat is very evident on OCT angio, probably even better than ICG. And this is critical for initiation of the treatment, though this is not important for cessation of the treatment, which is very clear from Dilraj's lecture today. We've got lots of important various types of case reports, very interesting, and I think they've all given a lot of food for thought for us. And one more important part of the management, which is also comes through, and I've been seeing this in my own patients. When you have a subretinal hemorrhage, you can't do anything else. Even if you continue with anti-VEGF agents over a period of time, the blood resolves without scarring. I think one of the cases which was showed that very clearly. So don't give up on the patient just because he says, well, I can't go through this surgery or this prone positioning. Just give him anti-VEGF agents on a regular basis, especially aflibercept in that situation, and you may get a good response over time. I think these are some of the points which I wanted to make, and I'll now leave it to Anand to finish off.
First of all, I'd like to say it's been an absolutely fabulous session, absolutely enthralling. 1.5 hours, time just flew by. We covered a huge amount of ground in that amount of time. Choroid is an area which is fascinating, and I think this advances in imaging capabilities, deep imaging, enhanced depth imaging, ultra wide field imaging, and multimodal imaging with autofluorescence, near infrared, all that is helping us understand more about this disease. I think we just scratched the surface. It's going to be very interesting. This space is going to be very interesting, the choroid, and a lot of answers are going to be solved there. But I wouldn't like to stand between you and dinner. I'd like to thank all the speakers for doing a great job. I'd like to thank Piyush and Abhishek for putting this together and masterfully steering this through. Fantastic. Good night, everybody. Thank you.
So before we end, perhaps the session coordinator would like to take a picture if everybody can switch on the cameras so we can have a picture.
Show all the images.
Thank you for the invitation and the beautiful afternoon, Pachychoroid afternoon.
From afternoon to night.
Thank you.
Exactly. No, here is afternoon.
The choroid is thick or not. Information came in fast and thick.
You're quite sleepy in the afternoon, Alex.
Okay.
Thank you.
Nice to meet you.
Thank you, everyone.
Thank you very much.
Bye-bye.
Good night.
Good night and have a